Welcome back. Today we're going to be in chapters 8 and 12. So hopefully you guys have had a chance to look through those a little bit. Chapter 8 is all about care of the pregnant woman during labor and birth when complications arise. And chapter 12 is going to be all about the term newborn. So we'll just jump right into chapter 8 here. Starting off, we're going to talk about certain situations when we might need to either induce a labor to get it started or to help a labor once it's started but maybe stalled out a little bit. So the formal definition of induction is the initiation of labor before it begins naturally, and augmentation is stimulation of contractions after they've begun naturally. We use what's called the Bishop scoring system to evaluate how ready or how ripe the cervix is, and that helps us decide what method we should use to induce somebody's labor. Preferably, we would like a score of 6 or higher, and that is telling us that that cervix is more favorable or more ripe for the contractions that the body might start experiencing. So this is what it's scored on. It looks at dilation, position of the cervix, meaning when you go to evaluate the cervix, is it really far back? We call that posterior. Or is it kind of mid-position? Or is it right there when you first enter the person's body? That would be more anterior. And then we look at effacement, and then we look at station, and then the consistency of the cervix. So how soft it is or how firm it is. And then we award points, either 0, 1, 2, or 3, based on our assessment. And then that gives us the score when we add up those points. So indications for a labor induction could be a particular medical reason, such as high blood pressure or maybe diabetes. It could also be problems with the fetus, such as placental insufficiency, intrauterine growth restriction. It could be a problem with the uterus itself, maybe an infection or something else. It could also be for fetal death. So sometimes babies will die in utero, and labor doesn't necessarily start on its own. And so in that case, usually when we find out that the fetus is deceased, we go ahead and induce her labor to get her delivered. Some contraindications to inducing somebody's labor, of course, are going to be any of the reasons that we would not want somebody to deliver vaginally. So that would include a placenta previa. If the umbilical cord had prolapsed, we would not want anybody to be induced. Both of those cases would be an emergency C-section. We would not want to induce somebody's labor if the fetus wasn't in a cephalic or vertex presentation. So if something else was presenting, like a breech presentation, or if the baby was in a transverse position, those would not be favorable for a vaginal delivery, and we would not want to induce somebody's labor if that were the case. We need to be careful about inducing somebody whose fetus is very high in the pelvis, so that baby really has not engaged, and you could be setting yourself up for a lot of problems in the area of usually umbilical cord prolapse. If the cord were to present in front of the presenting part once that presenting part gets engaged into the pelvis. Of course, we never want anybody to deliver vaginally if they have an active case of herpes lesions. If the mother has an abnormal sized pelvis or structure of the pelvis that would not be favorable for a vaginal delivery, that would be contraindicated to labor induction. And of course, we never want to induce somebody's labor if they've had a prior classical Cesarean scar. So any vertical scar on the uterus makes them a much higher risk for uterine rupture, and we never want those people to actually go into labor. So that would be contraindicated to induce their labor. There are lots of different ways that we can either induce or augment labor. some of the pharmacological methods to stimulate contractions. Probably the most common is going to be oxytocin, which is what we do is we make a synthetic form of oxytocin, which is naturally released from the pituitary gland during labor. The synthetic form is also referred to as Pitocin, and that medication is given IV, as an IV drip, and it's used to initiate or stimulate contractions. It can also make contractions that somebody's having stronger, and this is the most commonly used medication. It's very easy to deliver. We just hook it up into her IV and run it in on a pump so we can titrate it to how much is needed. And then as far as a cervical ripening method, we use some type of prostaglandin, and that's usually going to be in the way of Cervidil, which is what this picture is demonstrating on the top here. It looks like kind of like a flat suppository on a string, and that flat part is impregnated with medication. And what we do is we place that part of that device behind her cervix, and it stays there for about 12 hours usually. And it causes that cervix to get softer, sometimes thin out, and sometimes even dilate a little bit. But its main job is to soften that cervix and prepare it for contractions after it's been in for about 12 hours. There is another prostaglandin that we use called Cytotec. It's a slightly different form. It comes in a pill. Its other name is misoprostol. This could be administered by mouth, or it can be administered vaginally. Typically, we use a little bit higher dose if we're going to give it orally, and we use a lesser dose if we're going to give it vaginally. And this also helps cause that cervix to soften. It also will usually cause contractions to happen as well, so it's kind of a twofold effect. So either prostaglandin being an E1 or Cervidil being in prostaglandin E2 are used to help ripen that cervix. So when we have patients who are going to be induced or augmented, we absolutely need to make sure that they understand the risks and benefits associated with that. And of course, that's going to be the job of the provider. You absolutely need to have IV access before starting any kind of augmentation or induction, just because you never know what the effects are going to be, and we always want to be prepared. Sometimes it requires the patient to remain in bed for a certain time frame, especially if we're placing something vaginally. We need some time for it to just be against the cervix without her standing up or moving around. So it just helps that medicine kind of get a baseline and work better. And then sometimes we use a combination of different methods. So we could use maybe some Cervidil or Cytotec, and then several hours later we use maybe Pitocin. So a number of things can be used. One of the risks associated with induction or augmentation is giving her too many contractions, and we call that tachysystole. And if you remember the definition from last week, that is more than 5 contractions in a 30-minute period. So we'll always want to make sure that she's not contracting too frequently and that her body is getting that rest period in between contractions so that that uterus can be reperfused and that baby can be oxygenated. There's also some other ways that we can either augment or induce somebody's labor. And this can come typically it could also come in non-pharmacologic ways. So stripping the membranes or stripping amniotic membranes is what we call kind of a vigorous vaginal exam, where the provider finds the cervix and then just kind of rubs kind of around it. I wish you could see what I'm doing, but it's just a more vigorous exam where you kind of are just kind of maybe irritating the cervix a little bit, and sometimes that can release some prostaglandins that the body naturally has and cause that cervix to dilate. Transcervical balloon dilators are gaining a lot more popularity in the last few years, and that's that bottom picture there. That is an example of a Cook catheter. Basically, it looks like a Foley catheter, but it has two balloons that you can see that are blown up. One is placed inside the cervix into the uterus, and the other one stays on the outside. And they're like two big water balloons. Usually they fill them up with about 60 to 80 milliliters of fluid. And it just kind of puts some pressure on that cervix and causes that cervix to dilate. Sometimes Pitocin is used in conjunction with a Cook catheter. And typically what happens is over a period of time, usually several hours, up to 12 hours, eventually that cervix will dilate and thin out, and that catheter will actually just come out. It will fall out on its own, and typically the patient will be about 5 centimeters at that time. The other methods that are here on this slide, personally, I have never used myself. So I'll let you just read about those in your books, but in my 20-year career, I have not used those methods. Another method that's really popular, especially to augment labor, is called an amniotomy. And basically that's where the provider uses something that looks like this in the picture. It looks kind of like a crochet hook. And they kind of snag the bag of water, that membrane, and they cause that patient's bag of water to rupture. A lot of times once that bag of water ruptures, that will kind of help labor pick up. And so it's a pretty easy way to kind of augment a labor pattern, kind of get things moving if maybe they're stalling out or if we just want to kind of keep things moving. Some of the risks associated with an amniotomy, of course, is infection, because once that water bag is broken, we know that that is when she can develop an infection, especially if she has a prolonged labor. So ideally, once that water bag is broken, we would like to have the patient delivered within 24 hours before infection would set in. So it does commit the patient to delivery. There's really no turning back once the water bag is broken. With all of the other methods that we've talked about so far, like the Cervidil or Cytotec or Pitocin, if those aren't working, we can give the patient the option of stopping everything and sending her home to rest for a few days and bringing her back a few days later to try again. But once we do an amniotomy, that's not the case. So it does commit her to delivery. So some complications that can be associated with amniotomy in addition to infection, like I mentioned before, prolapsed umbilical cord, where that cord can fall in front of the presenting part. And then as that presenting part moves down through the pelvis and through the vaginal canal, it can actually put pressure on the umbilical cord, in effect just completely kinking it off. And then there's no blood flow going into the baby. So that is an emergency and does require a cesarean delivery. Sometimes also an abruption can happen when we break somebody's water bag, and that's due to a rapid decompression of the uterine contents. So especially if somebody had a lot of fluid and then it just comes out very quickly, sometimes that triggers the placenta to think, oh, it's time to evacuate myself. So it pulls away from that uterine wall and wants to come out as well, although the baby's not out yet, so that poses a problem. Because that is how that baby is getting oxygenated. So that also would be an emergency C-section. Once somebody's water bag is broken, we of course want to maintain their skin integrity by changing their linens, their chucks, and keeping them as dry as possible throughout the rest of their labor. So after somebody's water bag is broken, we will of course want to monitor the fetal heart rate and make sure that nothing consequential happens, such as a prolapse cord or an abruption. And so that's our first priority, is looking at that fetal heart rate and seeing how that fetus tolerated amniotomy. And then if the fetus is fine, then we're going to observe what color that fluid is, if there's any odor, and the amount that we're seeing. So sometimes when somebody's water bag breaks, we only see a little bit of fluid. Other times it's a big gush and everywhere in between as well. So we want to make sure we're noting the amount that we're seeing as well. We'll monitor her temperature about every 2 hours usually throughout the duration of her labor to make sure she's not developing an infection. And remember, the color of green in the amniotic fluid indicates that fetus has had a bowel movement and has passed meconium, usually related to some type of stressful situation that the fetus experienced in utero. An amnio infusion is something that can be done for a couple reasons. If we're seeing a lot of variable decelerations in the fetal heart rate, indicating that maybe there's some umbilical cord compression going on, what we can do is place this catheter inside the uterus and instill fluid to kind of help create more or take off some of the pressure that maybe that cord is sensing by instilling more fluid in there. It can also be used in cases if the baby has really low fluid and we want to instill a little bit more fluid. So it just provides some extra cushion for that umbilical cord. Some other ways that patients can possibly get their labor going and stimulate contractions. Walking can help stimulate contractions. It allows gravity to help pull that baby down onto the cervix and put pressure on the cervix, and that can make contractions be a little bit stronger, a little bit more effective in what they're doing. Also, women can use nipple stimulation to help secrete oxytocin from their pituitary gland. And that we know causes the uterus to contract. So some people who wish to have a more natural, non-pharmacological induction might try nipple stimulation to get their labor going. So again, one of the concerns that we have, there's too many contractions. We call that tachysystole. And so this is the type of pattern that you might see when you're looking at the fetal heart rate and the uterine activity. You can see how there's no rest in between those contractions. And that usually results in fetal compromise, and sometimes even it causes the uterus to rupture open. So we want to avoid patterns like this, and so it's our job as nurses to make sure that we manage the method that we're using and that we don't get into a situation like this. And if we do something about it. The next thing we're going to talk about is called a version. It's also called an external cephalic version. But this is a method that's used to change the presentation of the fetus. So typically when you have a fetus that's not in a head down position, so not cephalic, not vertex, the provider can manipulate the abdomen externally and try to help turn that baby so that it is head down. Usually they like to do this around 37 weeks, kind of before that baby gets too big. And so the doctor will bring the patient usually into the hospital. We'll do an IV. And sometimes medication is used to relax the uterus a little bit. Usually terbutaline is used. Sometimes, what's the other one? Nitroglycerin can be given as well. And it causes that smooth muscle relaxation, and it allows the provider to manipulate the abdomen a little bit easier. I'll just have you guys check out a video on YouTube to watch this, and it'll really give you an idea of how they go about doing that. I see them done fairly often, and I can say probably only about 50% of them are effective. So one of the things that we absolutely need to make sure our patients understand is that there are some risks of doing this version. So one of our jobs is we need to, like I said, make sure we have IV access just in case some type of emergent situation arises. And we also need to make sure that we have an operating room available and an OR crew ready to perform an emergency C-section should any problems arise. So you can tell from the pictures that I just showed you, when the provider's attempting to turn the fetus, one of the things that can happen is that it can cause the placenta to kind of shear off of the uterus. It detaches, causing an abruption. And so if that happens, usually what you'll see is a big change in the baby's fetal heart rate pattern, indicating that that baby is no longer being oxygenated, and then we would need to do an emergency C-section. Some contraindications associated with aversion are going to be anything that you wouldn't want someone to deliver vaginally with. So active herpes infection, if the mother's pelvis is not of adequate size, or if the fetus is too large, if we're talking like a macrosomic infant, where we think that it's just already big and probably not going to fit. If that placenta is very anterior, meaning like basically right where the provider would be manipulating the abdomen, we wouldn't want to attempt aversion there either. So it's important to know where the placenta is placed before doing aversion. Of course, if she's had a classical uterine incision prior, we would not want her to go into labor, and therefore we would not waste our time doing aversion to try to turn the baby. She does need to have adequate fluid volume, so somebody with oligohydramnios would not be a good candidate for aversion. And if that placenta isn't functioning well to begin with, we probably wouldn't want to cause further stress or chance shearing that off from the uterus, so we would probably not do aversion on a placenta that's not functioning well to begin with. Another risk associated with doing aversion is that fetus can become entangled in its own umbilical cord, and so that can cause some distress for the fetus as well. Episiotomies and lacerations are ways of enlarging the vaginal opening as the baby is delivering. So an episiotomy is where the doctor or provider performs some type of surgical enlargement. Usually it's either done with scissors or a scalpel, and the tissue is simply cut. Lacerations are when it happens kind of naturally, just with the baby's head coming out. And so it's kind of up to the provider at the time of delivery to decide if they're going to perform an episiotomy, or if they'll just go ahead and let the tissue tear on its own. So there's different schools of thought on which is better. When I first started my career in labor and delivery, episiotomies were very popular, and almost every patient was given an episiotomy. The theory behind that was that it's easier to repair. The tissue is more aligned, and it creates just a smoother repair. However, over the course of probably the last 15 years, we've really kind of switched and gone away from episiotomies, and now the school of thought is it's better to allow the patient to tear, if she is going to tear, just naturally on her own. And the theory behind that is that if you try to tear a piece of material, like if you grab the bottom of your shirt and you just took the bottom of it and you tried to tear it in half, it would be really hard. However, if you got a pair of scissors and you made a little cut in the bottom of your shirt, and then you took both sides and you tried to tear that, it would tear very easily. And so they were finding that when they cut an episiotomy, sometimes when the baby was delivering, it would cause that cut to kind of rip past where the cut was and go even deeper. And some people were having much more extensive repairs needed. Whereas if they just let their tissue tear naturally, it wasn't as deep or as significant. So right now we really don't do a lot of episiotomies anymore unless it's really necessary, usually in the case of distress, or if the baby is kind of stuck and just needs that extra room. Sometimes the doctors will still do them. But they're finding that it's better and it's better healing if the tissue tears on its own. There can be different types of lacerations, so different degrees of severity. First degree is going to be just your superficial vaginal mucosa or the perineal skin. Second degree is probably the most common that we see. It involves the vaginal mucosa, perineal skin, and a little bit deeper tissue of the perineum. Third degree would be similar to the second degree, but it kind of extends towards the anal sphincter. And then the fourth degree would be when it extends through the anal sphincter into the rectal mucosa. And that is just a very difficult recovery if the patient has a fourth degree. So this is very common. What it looks like here, just you can see where it's kind of torn, but not to the extent of the anal sphincter. So this would be your second degree, very common. Now with episiotomies, there's a couple different ways that a provider can cut an episiotomy. Some will choose to cut straight down, and then others will choose to cut off to the side. And the theory behind doing, like you see in the picture, a right medial-lateral episiotomy versus a midline episiotomy would be if the patient tore past the episiotomy cut, that if it were a right medial-lateral episiotomy, it would just tear off to the side and it wouldn't involve the anal sphincter or the rectal mucosa. So that's one of the reasons, one of the benefits of making the cut off to the side is you're still enlarging the area, allowing for more room for that head to come out, but you decrease the risk of tearing down into the rectal area. So that's kind of what we talked about already. Some providers would choose to do an episiotomy over letting the patient just tear on her own because there's clean edges and a little bit easier repair. Forceps are used in cases where a lot of times they're just used to help that baby rotate, or it can also be used to kind of work with the mother's pushing efforts to help deliver that baby. Forceps can also be used during a C-section if the provider is not able to get a good handle on the baby and if they need just a little bit extra help in getting that baby delivered. But basically they look like salad tongs, kind of. They're metal instruments, and they kind of go one on either side of the baby's head, and then they can either help that baby rotate or they can kind of help pull that baby out to be delivered. We don't see the use of forceps a whole lot anymore. Most providers choose to use vacuum extraction instead. But there are still a few physicians, especially older physicians, that feel more comfortable using forceps, and they're usually pretty good at it, and they're the ones who might still ask for them in a delivery. But most providers are more comfortable using a vacuum extractor such as this, where they place suction on the fetal head, and as the mother pushes, they're pulling, and they can help pull the baby out. So we would only use a vacuum extraction on a head, like vertex type position. And so that suction is just placed on the baby's head there, and then as the mom pushes, the provider pulls, and usually the baby can be delivered a little bit easier. The risks associated with vacuum extraction can be trauma to the maternal or the fetal tissues. It might cause the patient to have a laceration or maybe even a hematoma develop in her vagina. And it can cause bruising on the baby, either facial or scalp bruising, also lacerations or abrasions. It can cause a cephalohematoma or an intracranial hemorrhage. So there are some risks associated with each one, and it's up to the provider to communicate that to the baby. So these particular videos here, I think you've already seen. You saw them last week on Moodle. So they just kind of go over, they revisit how a C-section is done. So we're going to talk a little bit about C-sections and maybe why they would be indicated. So we know that a lot of people that end up having C-sections, it's kind of their plan B. So something maybe is not going perfectly correct with maybe a vaginal delivery or attempted a vaginal delivery, and so the provider recommends birth through the abdomen instead. It can be related to an abnormal labor or an inability of the fetus to pass through the mother's pelvis, either related to the size or shape of the pelvis or maybe the size of the fetus. Sometimes patients with conditions such as gestational hypertension or diabetes might have a higher rate of C-section just because of the complications associated with those. We know that anybody with an active herpes lesions will have a C-section because vaginal delivery is too risky that the baby would contract the herpes virus as well. A previous surgery on the uterus might indicate a need for a C-section. So a lot of times once somebody has one C-section, they'll elect to have a C-section with the rest of their deliveries. Now keep in mind that that is only an option to have a vaginal delivery after a C-section if she has a horizontal or a transverse scar, not a vertical scar. Sometimes we do C-sections because the baby is just not tolerating labor. And there's too much compromise going on, and so we do a C-section to kind of make sure we just get the baby delivered before it has oxygenation problems. And then we also do C-sections for things like placenta previa and abruptions. There are risk factors associated with C-sections. They include problems with anesthesia, respiratory complications, hemorrhage, blood clots, injury to other organs, most commonly the bladder or part of the urinary tract, delayed peristalsis, returning to the intestines, and of course infection. So it's up to the provider to educate the patients on all the risk factors that are possible and associated with C-sections, and then make sure that the reason that they're recommending the C-section outweighs those risks. In preparation for a C-section, we want to make sure that we look at the results of our CBC. So we want to identify if she has anemia or any blood clotting abnormalities. So we're looking specifically at her hemoglobin and hematocrit and also her platelet count. So we usually draw a CBC on everybody who's admitted, and we type their blood as well. Occasionally, we might do coagulation studies if there's an indication for doing that. We, of course, want to get a baseline set of vital signs, including the fetal heart rate and the maternal temperature, so that we can assess for any changes that might occur in either mom or baby. We're going to make sure that she's positioned for comfort, because once she is induced with anesthesia, she won't be able to do anything to change her body position. So we want to make sure that we account for that. She'll definitely need an IV. And she'll need a Foley catheter to keep her bladder drained, so that hopefully there's no trauma or any problems that happen to the bladder during surgery. We've already talked about the two different types of incisions that can be made. So the most common incision that they use is called a low transverse incision, and that's the horizontal incision. There also can be a vertical incision done as well, and then that is typically reserved for more emergent situations because it is easier to remove the fetus. It does take a little bit more work when there's a transverse incision, but if there's a vertical incision, then she absolutely will have to have C-sections with all of her other pregnancies. And she is at a much higher risk for rupturing her uterus down the road with another pregnancy. So we try not to use the classical incision if we can help it. It's only used if there's a real emergency to get the baby out. And this is typically what each of them looks like. So you probably saw in the video kind of the sequence of events and just how we kind of prepare the patient and the sequence of events that happen during a cesarean delivery. Usually we're going to be getting the patient numb first, and that's usually given in the way of a spinal. And then once we get her positioned, we will help our anesthesiologist get a look at all of her vital signs. So we usually do EKG, blood pressure, pulse ox. Then we'll prep the abdomen with whatever solution your facility uses. Sometimes it's betadine. The facilities I work at use a solution called chlorhexidine. And so we'll prep the patient's abdomen, and then typically they drape with a sterile drape. They might mark the incision with a pen, just kind of making sure that they get it in a straight line and that it's at the appropriate level. Then they'll make the skin incision and cut through the different layers, and eventually they'll reach the uterus and they'll make an incision on the uterus. If the bag of waters hasn't broken, they'll rupture that at this time, and then they'll deliver whatever is presenting at that area, either the head or the buttocks. Once that baby is delivered, then they suction the mouth and nose, and then they clamp the cord and hand the baby off of the sterile field. So when somebody has a C-section, a lot of times, like we've already talked about, it's kind of their plan B. And so they may not be anticipating having a C-section, but it might happen just unexpectedly. And so we'll just need to kind of assess where our patient is and if she's needing more support than your average patient might. Keep in mind that we also need to make sure that the support person or people have been told what's happening and that they understand, because it can be a scary time for them as well. So just making sure that everybody understands and is tended to. After the C-section is complete, we'll move the patient to the recovery room just like we would after any surgery. So we call that the post-anesthesia care unit, PACU. Most Level 2s and Level 3 hospitals have their own PACU in labor and delivery. So that's one of the nice things that I love so much about labor and delivery is not only do I get to take care of women in labor and we have normal vaginal deliveries, which is always great and fun, but we have our own operating room and our own PACU, and so it gives me an opportunity to do something a little bit different. So sometimes I might circulate in the OR. I can also scrub cases, so I can scrub in and hand instruments to the provider, to the surgeon, and I can also recover patients in our PACU. And so it just gives some variety to my job, and that's one of the things that I love so much about labor and delivery is no 2 nights really ever, 2 days ever look the same. So it's kind of neat to get to experience a little bit different stuff when you go to work. So in the recovery room, we're going to be monitoring her vital signs very frequently and assessing for any signs of hemorrhage or shock. We'll probably be giving her IV fluids, and it just kind of depends on the situation and the facility as far as what's given. We'll assess her fundus, making sure that it's nice and firm, that it's not elevated above the umbilicus, and that it's staying in a midline position, making sure that she's not bleeding too much. We'll be assessing her dressing for any drainage or any problems associated with the dressing. We'll be looking at her lochia for the amount, the color, and the presence of clots. And then, of course, she still has her Foley catheter in place, and so we'll just be making sure that her urinary output is adequate, keeping track of her I's and O's. So it's just as important to assess somebody after they have a C-section as it is after they have a vaginal delivery. We want to make sure that that uterus is clamping down and it's nice and firm, that it's not bleeding too much. But when we massage the fundus, we also have to keep in mind that she does have an abdominal incision, which is usually very painful when you do a fundal massage. So even though it might be more painful for her, we just need to make sure that we're kind of balancing, making sure she's comfortable with any pain medications that might need to be given, but still doing our job to assess her fundus appropriately. Now we're going to kind of switch gears and talk about some of the problems that we might encounter during labor. So a lot of times what happens is labor maybe stalls out or it just doesn't progress like we would expect it to, and that's usually referred to as a dysfunctional labor pattern. Dysfunctional labor just means it's not progressing. And then a dystocia of labor is a difficult labor by definition. And so typically, if you remember back to a couple weeks ago, we talked about the 4 P's of labor. Abnormal labor can be associated usually with a problem with one of those 4 P's. So some risks for a dysfunctional labor could be advanced maternal age, and remember that's usually going to be anything over the age of 35. Obesity, over-distension of the uterus, either from too much fluid, so we call that polyhydramnios, or maybe multiple fetuses. We could have an abnormal presentation. So maybe the baby is technically head down, but that head is in there kind of cockeyed, and so it's not coming through the pelvis like it should. We can have what's called cephalopelvic disproportion, where that baby's head is just too large to fit through the pelvis of the mom. We can have overstimulation of the uterus, where we're causing too many contractions and that uterus just gets tired out and doesn't want to work. We could have maternal fatigue, dehydration and fear, or we could have a lack of analgesic assistance and the mother's just not able to relax, and therefore her dilation and effacement kind of come to a halt. So let's talk about the problems associated with the powers of labor. So remember, our powers are going to be our contractions. So when we have a hypertonic situation, that means that the muscle tone of the uterus is increased, and it usually occurs during the very early part of labor, so that latent phase of labor. It's usually characterized by contractions that are very frequent and kind of crampy-like, but they're not very well coordinated and they're not effective at producing cervical change. So the patient perceives them as very painful, but they're not productive. They're not causing that cervical change. They're not causing labor to progress. And then we can have a hypotonic situation where we have decreased muscle tone of the uterus. Typically we see that when labor begins normally, but then for some reason it just kind of peters out during the active phase and she kind of stops progressing. This is more likely to occur if the uterus is overdistended with either too much amniotic fluid or multiple fetuses. Sometimes we have ineffective pushing efforts where maybe for whatever reason the patient just isn't pushing very forcefully, and so that baby is not really descending through the birth canal. It may be related to exhaustion if her labor has gone on for a long period of time and she just doesn't have the energy to push. Sometimes we see it if the epidural is really dense and she just can't feel any pressure down there and she doesn't really know how strongly she's pushing. Or maybe she's fearful about the whole pushing efforts and possibly tearing. We've had patients that just flat out refuse to push. They're just too scared. And so it just kind of depends on the situation, what's going on. But sometimes labor might stall out if she refuses to push or just can't push. Then we have problems with our passenger, the fetus. It could be related to the size of the fetus or what's presenting. So again, if we had that cephalopelvic disproportion, or if that baby was just kind of in a weird position, if that pelvis was pretty small and the fetus was larger in size and just can't fit through, or maybe if there's more than one baby in there, or maybe possibly birth defects. So the term macrosomia is used for a fetus that weighs more than 4,000 grams, and that's 8.8 pounds. It just makes it for a much tighter fit, and it can contribute to hypotonic labor dysfunction. Shoulder dystocia is a term that we use as an emergent situation when the fetus's head has delivered, but the shoulder gets caught up on the symphysis pubis. So that symphysis pubis is that hard bone that the fetus has to come under. And so sometimes the head will get delivered, but then one of the shoulders gets caught up and it kind of gets stuck. This is an emergency, and so we need to perform some different things, different maneuvers to kind of help the situation. But sometimes they might have to do an emergent C-section if nothing is working. So it just kind of depends on what's happening and what the provider is doing or has done, and then we kind of proceed from there as far as how long it's taking and what we need to do. Occasionally, the provider might have to reach up where that shoulder is stuck and break the clavicle in order to collapse that shoulder to help it come under that symphysis pubis. So of course, we wouldn't do that as a first line measure, but sometimes it needs to be done in order to get that baby delivered. I'll add this video that I found on YouTube. I think it ended up being a video that they weren't necessarily filming for shoulder dystocia, but it ended up being a shoulder dystocia, and it was I just think it's really cool the way the staff handles it. You can definitely tell that they're starting to get nervous and anxious, and it's kind of interesting to watch them work through all of the different maneuvers that we try in order to get this baby unstuck. Typically we try what's called McRoberts maneuver first, where we kind of help the woman to open her pelvis by getting her legs open and pushed back as far as they can go to help create as much space in the pelvis as possible. And then the provider can go in and try to rotate the baby so that that shoulder kind of rotates down and comes under that bone. The provider can do an episiotomy to help create more room so that they can usually get their hands in there to help the baby either rotate or pull an arm out to make more room so that that baby can come under the symphysis pubis. We can also do what's called suprapubic pressure, where a nurse kind of gets up on top of the patient and presses with the heel of her hand over the symphysis pubis to try to help collapse that shoulder and get it to come under that bone. And you kind of see these different things play out in this particular video. So make sure you check that out on Moodle. It's really interesting. We can have an abnormal presentation of the fetus or an abnormal fetal position, and basically that just means usually that's like in your occiput posterior position, where that largest part of the fetal head is trying to come through the smallest part of the pelvis, and that can create some problems as well. If that baby's not passing easily through the pelvis, it can get hung up, and that can delay labor or make labor last longer. It can put pressure on the cord, which we know can cause distress in the fetus by decreasing the amount of oxygen that fetus is getting. And it might result in that fetus needing to be rotated by the provider. Abnormal positions, again, might be with that occiput posterior position, causing labor to last longer because it's just a much tighter fit. She definitely will experience more pain in her lower back as that occiput is rubbing on the sacral area or that coccyx. And sometimes either vacuum extraction or forceps could be needed to help that baby deliver. So we try to avoid doing breech deliveries vaginally. Usually if a baby presents in the breech position, we'll do a C-section because it is possible for that head to kind of get stuck. After the body delivers, the cervix can clamp down around the baby's neck, and it just can create a much tighter fit and cause some problems. So we tried, if we can, to deliver those babies in a C-section. Sometimes if a baby is in an abnormal position or presenting abnormally, we might need to assist our patients into different positions to maybe help that baby rotate or help that baby move into a different position. And usually the positions that we ask our patients to get in involve anything that's going to help open her pelvis and create more room, and also help create as much oxygen to that baby as we can get. So we can do things like sitting, kneeling, standing. We can get her on her hands and knees, which helps the baby to possibly rotate into a more occiput anterior position. We can use sideline positions, squatting positions, especially in the second stage of labor when she's pushing. And then sometimes another good idea is placing one foot on a chair with the other knee or with the other foot down on the ground, and that kind of helps create her pelvis opening even larger. In cases where we have more than one fetus, sometimes we can see a dysfunctional labor pattern associated with that. Sometimes the uterus is so over-distended that it leads to poor contraction quality. Even though one fetus may be in a head down or a vertex position, the other baby or babies may not be. And so that can cause problems with things like a cord prolapse after the first baby delivers. And sometimes the babies will change position in utero. If they're, especially after that first baby delivers, that second baby can flip to a breech position. So multifetal pregnancies are just a little bit more complicated when it comes to delivery. Problems with the pelvis. So this is the passageway that we talked about in one of our 4 Ps. That gynecoid pelvis, again, is going to be the most favorable for vaginal birth, but occasionally not everybody has a gynecoid pelvis, and so we can see problems with the actual bones of the pelvis not being wide enough. And then sometimes we also see soft tissue obstructions that can come most commonly in the way of a full bladder. So that's one of the reasons why we try to encourage our patients to void frequently, empty their bladder, so that that's not preventing that fetus from moving down. And then we also see soft tissue obstructions in more commonly with our obese patients. So it's just another reason why we hope that our patients maintain healthy weights throughout their pregnancy. The psyche is another area, another P that we've talked about that can really have an impact on how labor progresses. So the most common problems associated with the psyche can be the lack of pain management. And so their bodies are just very tense and not able to kind of progress through the labor progress on their own. It might be the absence of a support person, and so she doesn't feel supported, or maybe she feels alone or scared. That can really impede and cause more tension. If she feels restricted to the bed, like she can't get up and move around, that might cause her to have an impact on her psyche. Or maybe she feels like her cultural traditions aren't being respected, and that can kind of shut down her progress through labor as well. So we talked about how when somebody is anxious and tense, that their bodies can secrete different hormones that cause problems to happen in the labor progress. So it causes epinephrine and cortisol to be released, which can cause a decrease in blood flow to the uterus because the body tries to spare its most essential organs when these hormones are being released. And so it preferentially gives blood to the brain, the heart, and the adrenal glands. And consequently, the uterus gets less blood flow, less oxygen. And so we start to see some changes in our fetal heart rate pattern because of that. So if that uterus isn't getting enough blood flow, we might see changes in our baby's fetal heart rate pattern. We can also see if the uterus is using more glucose for energy during labor, and then if that glucose gets diverted away from if the glucose gets diverted away from the uterus, that can be less glucose available for the uterus to contract. So that can cause a delay in progression of labor. That increase in tension of her pelvic muscles can impede fetal descent, and it can cause her to perceive more pain. So the effects of those hormones are, I think it's something that we may not think about all the time, but it definitely has an impact on labor. When we start to be concerned that maybe our patient's labor is dysfunctional or abnormal, we use this graph here to kind of map out how labor's been progressing, and we can kind of see what the normal should be and then kind of where she falls on her labor progress. So this would be a normal Friedman's curve where you have a slow amount of fetal descent until really she gets into active labor at about 6 centimeters or so, and then those two curves kind of cross, and that's how labor normally progresses. Sometimes that bottom line can be really drawn out for a long period of time, and so you'll see a change in the Friedman's curve, and that kind of lets us know that her labor isn't progressing normally. A precipitous birth is a birth that's completed in less than 3 hours, so it's just one of those really fast labors that it just is really intense. Labor begins very abruptly and intensifies quickly. She might have very frequent and very intense contractions. These patients have a higher risk of uterine rupture just because everything happens so intensely and so quickly, and instead of being kind of a slower gradual curve like we saw in that Friedman's curve. Also, she might have a higher risk for cervical lacerations or even a hematoma to develop. Fetal oxygenation can be compromised as well, just from very frequent intense contractions and a decreased amount of oxygen to the baby. Sometimes we see the babies, when their births happen very quickly, we can see bruising to their face as if they come down very quickly against the perineum. And sometimes we can even see intracranial hemorrhage and nerve damage in our fetuses as well. Premature rupture of membranes is when the water bag breaks, but labor contractions don't necessarily begin. And we know that once that water bag has been broken, she's at a higher risk of developing an infection. So a lot of times if labor doesn't begin spontaneously after that bag of water breaks, her provider will discuss with her options to kind of augment or even induce her labor just to prevent that risk of infection. So teaching as far as if our patients have their water bag break early, we just are going to let them know that we're going to monitor them for any signs and symptoms of infection. We definitely don't want her having any sexual intercourse or placing anything into her vagina that might push bacteria up into the uterus. We're going to encourage her to avoid orgasms and breast stimulation. And she might, if we're going to try to keep her pregnant, so like if her water bag breaks and she's not quite near her due date yet, we might try to do some bed rest for a period of time to see if we can get that baby to grow a little bit more before getting her delivered, but keeping in mind that we have to balance that with monitoring her for signs of infection. So it's kind of a push-pull type situation where you hope for the best but prepare for the worst. So preterm labor is when labor occurs after 20 weeks but before 37 weeks gestation. Unfortunately, there are lots of problems associated with the immaturity of a preterm baby, and we will talk about premature babies next week more in. But some risk factors that are associated with a preterm labor could be any one of these here. Unfortunately, we don't really know what causes preterm labor to start. If we did, we certainly would take measures to try to prevent that from happening. So obviously there's some things that we can control, like if we would encourage our patients not to smoke, have good nutrition, those types of things, not to use drugs, manage stress. But there's a lot of things that we really don't have any control over, and unfortunately can lead to preterm labor. So we just have to do our best with what happens and what we're presented with. Some signs that premature labor might be impending could be when they look at the cervical length, usually around 20 weeks gestation, patients who are at high risk for developing preterm labor have a shorter cervix. So that cervix has already started to efface and get thinner. And the patients that have that happen around 20 weeks or even prior to that are at high risk for delivering early. We can also do what's called a fibronectin test or a fetal fibronectin test, sometimes referred to as FFN. That's where we swab the vaginal secretions and send that off to the lab. And the presence of fibronectin, which is a protein produced by the fetal membranes, if that's detected in the vaginal secretions, that usually is a sign to us that she might be going into preterm labor. She might have an early delivery. And so it's one of the things we can check for in our patients that come in saying, you know, maybe they're having contractions or they're feeling a lot of pressure. We can do this FFN test and see if it's positive or negative. If it's positive, it is likely that she will have an early delivery. If it's negative, it is likely that she will not deliver within 2 weeks. So it kind of gives us an idea of how to better manage our patients if they're threatening preterm labor. Some different symptoms that our patients might present with in preterm labor could be contractions. Sometimes they feel more like not necessarily pain, but just a tightening in the uterus and the abdomen. Some patients will describe the feeling as menstrual cramps or a low backache. Other patients will just say they feel a sense of pressure or heaviness in their lower abdomen or in their vaginal area. They might notice a change in their vaginal discharge. They might have abdominal cramps, either with or without diarrhea. And there might be pain or discomfort in the vulva or the thighs. Or sometimes they'll just have a feeling that something's not right. And so they'll come in to be checked, and lo and behold, they'll be in preterm labor. One of the things that we typically will do is called tocolytic therapy. So tocolytics help stop the patient having contractions. So it's medications that cause that uterus to relax and not contract. The goal of tocolytic therapy is maybe just to buy her some more time so that that fetus can continue to grow. A lot of times we'll try to give that baby a shot, or actually 2 shots of steroids called betamethasone to help prepare their lungs to have to start working a little prematurely. We will sometimes give magnesium sulfate for more preterm patients. They found that magnesium sulfate given to preterm babies really helps protect them neurologically. We might use a medication called terbutaline to help relax the uterus. It relaxes smooth muscle, and the uterus being smooth muscle will help that uterus stop to contract. We can use prostaglandin synthesis inhibitors such as indomethacin, and then we can also sometimes use calcium channel blockers such as Procardia, also called nifedipine, to help relax that uterus as well. So like I said, steroids might be given to the mom that will help the fetal lungs to mature earlier than they normally would. So that hopefully there's not as much respiratory distress in our babies that are born early. If there's any infection, if we sense that maybe she's having preterm labor because of an infection, we'll try to treat that with antibiotics. Usually these patients are placed on bed rest and hydrated because a lot of times the uterus will contract if it's dehydrated. It causes it to be irritated. And so sometimes we can manage the contractions and get them to go away if we can just hydrate her more. Now we're going to kind of swing to the other end of the spectrum and talk about a prolonged pregnancy. And a prolonged pregnancy is one that lasts longer than 42 weeks. The problem with this is that after about 40 weeks, the placenta really starts to age and it doesn't function very well anymore. And so the ability of it to deliver oxygen to the baby and excrete the waste products from the baby diminishes. And so what we have happen is a decrease in oxygen to the fetus and a buildup of waste products in the fetus. And that can cause changes in the baby's acid-base balance by creating a more acidic environment for that baby. It can cause that baby to lose weight, and the skin might peel. And it sometimes results in that baby encountering distress situations and releasing meconium into the amniotic fluid. Also, we can see low blood glucose levels in the fetus as that pregnancy is more prolonged. Once somebody reaches 40 weeks gestation, if they are not delivered, usually the providers will start increasing their assessments of the fetus and the patient. And they do that in the way of what we call non-stress tests. And basically, that's just placing the patient on the external fetal monitor and watching the patterns of the fetal heart rate for about 20 to 30 minutes. If there are good indications, then the test is over. If not, then the test is more prolonged, and we're going to be looking more closely to see if the baby's in any distress. We can also do what's called an AFI, or an amniotic fluid index, and that's basically just measuring how much amniotic fluid is still in the uterus. And after 40 weeks, that starts to diminish quite a bit as well. So usually each week the amniotic fluid will decrease by about a third. And so that's why another reason why we don't want patients to go past their due date too long, because we really see a decrease in the amniotic fluid, which causes less cushion to be available for the umbilical cord and more compression on that cord because there's less fluid. We can also do a test called biophysical profile, and that's done using an ultrasound. It looks at some very specific categories and awards points in those categories. And it's just a way of helping us identify if that baby is doing well in utero or if it should be delivered. And then we can also recommend our patients doing kick counts, where they actually count how many times that baby moves in a certain period of time, so maybe like an hour or 2 hours. And that can be reassuring that that baby is doing well, because the theory behind that is sick babies will start to restrict their movement and they won't move as much. And so if a baby is not being oxygenated well, it will start to restrict its movements and the baby's movements will really decrease. And so one of the ways that we can tell if that baby's doing well is if it continues to move around a lot inside. So we've already talked about some of these particular emergencies kind of throughout our lecture so far. We talked about a prolapsed umbilical cord, where that umbilical cord drops in front of the presenting part. It can either be a large part of the cord or just a very small part of the cord, or sometimes an occult cord where you really can't see anything. You can't really see the cord, but it is being compressed somewhere. Maybe that cord is just kind of being pinched by the baby's skull, but it's not something that we can really feel on an exam. And then we have uterine rupture. That can happen in different stages as well. It can either be complete, incomplete, or dehiscence. So it just depends on how much of that uterine muscle has torn open. So here's some pictures of a prolapsed umbilical cord. You can see how sometimes it's just a little bit of the cord, and other times it's a lot. So the different types of uterine rupture, like we said, can be complete, incomplete, and dehiscence. A complete rupture would be a hole in the uterine wall into the abdominal cavity. Incomplete would be where it just tears slightly into a nearby structure, or like a ligament, but not all the way into the abdominal cavity. And dehiscence is where an old scar actually separates. So risk factors for a uterine rupture include a previous scar on the uterus. Of course, that's going to be the easiest to tear open. It can also happen if we cause too many contractions, maybe if we're giving medication like Pitocin to give her contractions, and if we're giving too much of that, it can cause the uterus to rupture. Also, blunt abdominal trauma can sometimes cause that uterus to rupture as well. So things like car accidents or a fall can cause the uterus to rupture as well. Your characteristics of a rupture are going to be signs and symptoms of shock. So once that uterus opens or tears, there will be significant bleeding into the abdomen. Not necessarily vaginal bleeding, although you can see vaginal bleeding when the uterus ruptures. But eventually she'll have a great deal of pain if she hasn't felt it all when the uterus first ruptures, because as that abdomen fills up with blood, it will cause severe pain, sometimes in the chest and between the scapula and on the backside. You will probably lose your ability to detect contractions because the tone of the uterus is now there is no tone, because once it ruptures, it doesn't have the same tone that it had before, and so you might not be able to see her having any contractions anymore. You definitely will see a change in the fetal heart rate as the perfusion to the fetus decreases due to the amount of blood being lost. The fetus will have some pretty significant changes in the heart rate. Typically, it'll either be late decelerations or it could even be bradycardia. Also, if the nurse tries to do a vaginal exam, she may notice that she's no longer able to feel the presenting part of the fetus, because as that uterus opened and ruptured, the fetus can actually migrate through that opening and move away from the cervix. And so when the nurse does an exam, you may not be able to see or feel what's presenting anymore. So these are just some different pictures of a uterine rupture so that you kind of get an idea of what's happening. Now we're just going to talk a little bit for a second about amniotic fluid embolism. This also is known as anaphylactoid syndrome. They think what happens is amniotic fluid and its particles, such as vernix, fetal hair, sometimes meconium. So remember we said that the maternal and the fetal circulation systems are separate, but occasionally, like during delivery, maybe there is a moment when some of the amniotic fluid could enter the maternal blood system and it creates an embolism. So those parts would travel to the lungs and cause essentially like a pulmonary embolism, but it's being caused by amniotic fluid volume or the contents within the amniotic fluid. It's usually characterized by an abrupt onset of hypotension, respiratory distress, and it usually ends up leading to coagulation abnormalities in the way of DIC. And so it can be a really scary situation, and it used to be that amniotic fluid embolisms were about 80% fatal. And there was really nothing we knew to prevent them or other than just identify when they're happening. And so it's one of those things that there's not a lot we can do except to support her respiratory center, do chest compressions if her heart stops, and then if she ends up going into DIC, replacing the blood that she's losing. So again, a little bit about our treatment. We'll, of course, bag her if she has respiratory distress or respiratory arrest. We usually try to treat her, get an IV going if she doesn't have fluid running, or at least bolus her. We'll replace any blood loss that she's had with either platelets or fibrinogen or even packed red blood cells. We'll have to monitor eyes and nose very carefully. She'll definitely have a catheter to help us keep track of her kidney function, pulse oximetry to help keep track of her oxygen saturation, cardiac monitoring in case she has any abnormal rhythms. And these patients definitely will not stay on a normal labor and delivery floor, but they will usually be transferred to ICU for closer monitoring. So that is the completion of Chapter 8, and now we're going to switch gears and turn all the way over to Chapter 12 and talk a little bit about our term newborn and what's normal for a term newborn. So we talked a little bit about some of the changes that take place when that baby comes out into air. So remember, it's so far it's been in a liquid, a fluid environment, and now it is delivered and it has to switch over. That umbilical cord that's been delivering oxygen is now clamped and cut, and now that baby is going to have to adjust to its own lungs providing its body oxygen. And this adjustment can be dependent on lots of things, specifically genetic background, the health of the patient, the mom, and the uterine environment that the baby was in, what kind of delivery happened, if there were any extraneous circumstances that were associated with the delivery, and care during the first month of life for this baby. So remember, we said that big change has to take place between that baby living in water and now that baby coming out and living in air, and its lungs really needing to take over that job of providing oxygen for this baby's body. It is a change that takes place. It's both sensory and physical. That first breath that baby takes will help open its alveoli and keep the alveoli open so that air can be exchanged. And it initiates cardiopulmonary interdependence. So that baby's heart has to pump the oxygenated blood that it's able to get from the lungs to sustain its life. Also, that baby's going to have to start metabolizing its food. The liver's going to have to start working. Up until this point, the mom's circulatory system was excreting waste products for that baby, and now that baby is going to be responsible for doing that on its own. Its kidneys are going to need to concentrate urine to help maintain fluid balance, and its neurological system will eventually get more mature as this baby grows. So when we observe the newborn, we need to make sure that we identify any abnormal situations, any deviations from normal, and make sure that those are reported to the providers right away. We're going to kind of do a little, we're going to talk a lot about each individual systems of the baby and kind of what's normal and what's not normal. One of the things that is unique about babies when they're first born is that they really don't have a lot of control over their body movements. So they tend to just have very gross motor movements versus fine motor movements. They are born with reflexes, which will help keep them alive. These include blinking, sneezing, gagging, sucking, and grasping. And we know that they can also cry and swallow and lift their head slightly when lying on their abdomen. So those are all things that they just kind of do simultaneously without, just kind of involuntary. They just kind of happen. I'll add these videos to Moodle so you guys can see the different reflexes that babies are born with. Make sure you understand what the Moro reflex is, what the rooting reflex is, what the tonic neck reflex is, and what the dancing reflex is. So I think if you see them on these videos, you'll have a much better understanding, and it'll help you remember what those different reflexes are. So now we're going to kind of start at the top and kind of move down. We're going to talk about all the normal findings that we find in newborns. During delivery process, the bones of the head could have molded slightly, causing that head to elongate. So remember, one of the ways that babies kind of help fit through the pelvis is by those the bones of the skull kind of overlapping a little bit. Because those bones aren't completely fused yet, they're able to kind of overlap and create a smaller circumference for that head to fit through the pelvis. But when they do that, there can be some molding that happens, and that's just that more elongated shape of the head. That will usually go back to normal, and the head will be more rounded after a couple days. But it is, even though it's a normal finding, we do need to make sure that we identify that there is molding if it is present. They could have some swelling of the soft tissues of the scalp. We call that caput. And then we might also see what's called a cephalohematoma, which is a collection of blood beneath the periosteum of the cranial bone. The thing to keep in mind, and the way we can differentiate between caput and a cephalohematoma, is whether or not that swelling crosses over the suture line. So the cephalohematoma will not cross the suture line. It is just in one particular area. The caput can cross the suture line, and so that's one of the differentiations that we can see when we are doing an assessment on these babies. Babies are also born with soft spots, or they're called fontanelles, and they protect the head. They allow for that brain to continue growing, and they don't close for several months to after a year after that baby's delivered, to allow for their brains to continue growing without putting pressure on their brains. So this is just an example of what a molded head would look like, where that baby was just kind of a tighter fit through the perineum and through the pelvis, and caused that elongation of the head. So the ears should be well developed. However, they are pretty small. Babies do have the ability to hear when they're born. Usually sneezing will help the drainage in the ears to go away. Sneezing helps clear those eustachian tubes of fluid. And so that's one of the things that has to happen in order for babies to start being able to hear. So it's a good thing when we hear babies sneeze. Babies can definitely react to sounds that they hear by seeing an increase in their heart rate or respiratory rate, or even seeing them do the little startle reflex or that Moro reflex. They can respond to voices that they hear, and in time they'll start to learn the sounds of their parents' voices and the caregivers that take care of them, and they'll eventually be able to recognize and differentiate people. Every newborn is screened for hearing before they leave the hospital, and it's just a way that we can maybe identify those babies who might have a little bit more trouble or have any problems, and just kind of help watch them as they grow and provide different help if they need it. As far as what babies can see when they're born, basically they just see black and white, and they can only really see about 12 inches from their face. So it's best to just use things that have that color contrast. So black and white is usually the best thing for babies to see for the first few months. Your books say that tears are absent for a couple months of age, but I have seen a newborn make tears, so I don't know if that was an abnormality or if there was some issue, but I actually have seen it personally. So not all babies have tears that are absent, but typically when they cry, they don't make tears like we do. Babies can get sensory overloaded if there's too much stimulation, so we want to make sure that we keep the environment stimulation down so that they don't get overloaded. So we can do that by creating a calm environment, maybe keeping the lights dimmed, and not having a lot of alarms going off on our medical equipment while they're in the hospital. So babies will sleep a lot initially. About 15 to 20 hours per day is normal. So first, when babies are born, they tend to be very awake and active for about the first hour of life. And then they tend to fall into a pretty deep sleep cycle where it's very difficult to wake them up for anything. And that can last for several hours. And then they'll wake up again and be more active. And then they kind of get into a better pattern where they're sleeping for about 2 hours at a time and then wanting to eat, and sleep for another 2 hours at a time and wanting to eat. But they do have REM like we do. They have different periods of sleep, as you can see over on the right, where they have quiet sleep, REM sleep, time when they're actively alert, a time when they're more quiet but alert, and then a time where they might be a little bit more fussy. But we just need to educate parents that it is normal for their babies to sleep a lot. And then after the first couple days after birth, they usually get into a more predictable pattern of sleep-wake cycles. We know that pain in infants is real. It actually causes them to produce catecholamines and cortisol, which causes changes in their heart rate and respiratory rate. It can also cause an increase in their blood pressure and the amount of glucose that their bodies use. So we don't want our babies to endure long periods of pain. And so we want to make sure that we try to relieve any pain that they might be having so that they don't get too exhausted or have any delay in a healing process. So there's different ways that we can assess pain in newborns. Obviously, we can't ask them like we can adults. And so we have different types of assessment tools that help us identify changes in their vital signs, changes in their body positioning that might tell us if they're experiencing pain. So babies also have conditioned responses where they learn over time. They're very smart. They learn things like who is going to be delivering food to them. So they know, they get to know voices, and they relate that to getting some sort of positive reinforcement. And just keep in mind that emotions are particularly subject to this type of conditioning. So we can really cause changes to happen based on how we respond to them. Neonatal Behavioral Assessment Scale measures the inherent neurological capacities and their response to selected stimuli. Some different areas that are tested include their alertness, their response to visual and auditory stimuli, motor coordination, level of excitement, and organizational process in response to stress. Their little respiratory systems have to kick in once they are delivered outside of the uterus. And that happens, that the respiratory center gets stimulated once the umbilical cord is clamped and cut. Then it becomes the job of the lungs to take on the exchange of oxygen and carbon dioxide. So with that first breath, like we mentioned, those alveoli open and expand, and will continue maintaining being open for the exchange of oxygen and carbon dioxide. So it's most critical during that first hour of life. That's when the most problems happen with the respiratory system. And so for that reason, we watch them very closely for that first hour after birth. We always want to keep them on their backs because their heads are fairly heavy, and we don't want them to get smothered by not being able to lift their head and keep their airway open. So we always put babies on their backs so that they have the best position for air exchange. We use bulb syringes to help clear airways. So initially when babies are first born, their mouth is suctioned, hopefully before they take in that first gasp of air. And then we'll suction the nose as well, just to remove any mucus or any secretions, any amniotic fluid that the babies may have left over. We do this, if you've ever seen a bulb syringe, you depress it first, and then you slide it into the baby's mouth or nose, and then you let it go, and it creates that vacuum and suctions out any fluid that might be in there. Also at delivery, we're going to assign the APGAR score, and I know we mentioned this a couple weeks ago, what that looks at. It measures 5 areas and awards points based on how this baby is making that transition. It looks at heart rate, respiration pattern, muscle tone, reflexes, and color. And that kind of gives us an idea of how this baby is transitioning from that fluid-filled environment to an air environment. So we score these babies at 1 and 5 minutes, and then every 5 minutes after in increments until we reach a score of 7 or higher. Most babies will receive an 8 or a 9 at the 1 and 5 minute mark. That's very common, very normal, and so we can stop giving APGAR scores after 5 minutes if the they're at least over 7. But it does kind of help guide any resuscitation efforts that we might need to do, and it kind of just gives us an overall idea of how these babies are making that transition. So you can see here what how we award those points for the Apgar score. As far as the baby's circulation system goes, they have approximately 300 milliliters of circulating blood volume. Now, when you think about that, that's a little bit more than a can of Coke. So it's not a lot. And so any slight loss of blood could have a big impact on these babies. Remember when we talked about fetal circulation, we talked about the different shunts that they have to give preferential blood flow to those organs that really needed it. So now that the babies are in an air environment, those shunts are going to close. However, if they fail to close, then we could see some problems with cyanosis and respiratory distress. So it's important that those ducts do close once those babies are born and that umbilical cord is clamped and cut. Maintaining thermoregulation is really important in babies. They don't have the ability to generate heat on their own. They have very thin skin, and so they tend to lose their heat very quickly. So we need to really prevent them from losing heat by maintaining their warmth. And we do that by drying their wet skin and then keeping them covered with blankets. Preferably, we'd like to keep them skin to skin with their moms and with a blanket over them, but if we can't do that, then we definitely want to either keep them under a radiant warmer or in blankets to prevent heat loss. So skin to skin is going to be our first choice, and then if we can't do that, we would keep them under a radiant warmer or in blankets. So normal newborn vital signs are going to be similar to fetal vital signs. So we want their heart rate to be between 110 and 160. We want their temperature to be less than 99, greater than 97. So anything less than 97 is going to be a little concerning. Really, I tend to see in my facilities that I work in 97.4. Anytime it's less than 97.4, we tend to get concerned. And then for respiratory rate, we want it between 30 and 60. And then we hopefully won't see any other problems with respiration. So we don't want to hear any noisy respirations, and we don't want to see any nasal flaring or chest retraction. Those would be signs to report to the provider as an indication of respiratory distress. So here's a question for you. If a neonate's vital signs are assessed as follows: temp 96.5, pulse 125, and respiratory rate 44, which of these is abnormal? Hopefully you guys can answer that very easily because we just talked about it. So keep in mind that babies will lose heat the same way adults do, the same way heat is lost with anything. It can be through conduction, convection, radiation. And there's one more. It's escaping my mind right now. Conduction, convection, radiation. Have to come back to that. Anyway, so we want to keep our babies covered as much as possible. We want to keep them dry so that they're not losing heat through wet skin. We don't want to place them on any cold surfaces. We want to make sure that we warm the surface if possible. We don't want to place them by any drafts, so not next to a window or a vent. And then, of course, we'll keep them covered to prevent that heat from escaping. As far as their musculoskeletal system goes, most of their bodies are made up of cartilage that will eventually turn to bone. But right now, in this newborn phase, they are mostly cartilage. Most of their movements, like we said, are going to be very gross motor movements. So fine motor is not yet mature. Their movements will be more random and uncoordinated. And their muscle development and control will proceed from the head down to their feet and out from the main stem of their body to the periphery. Their head and neck muscles will be the first ones that they will gain control over. And so you can see how that progress will work from the head down. Average length for newborns is going to be between 19 and 21 inches. Average weight is between 6 and 9 pounds. It is normal for the first couple of days of life for that baby to lose a little bit of its birth weight, but then it usually will gain it back within the next week or so. And this is just a result from the withdrawal of maternal hormones, fluid shifts, and the loss of stool and urine. So you can see the size difference here. In babies, they do come in all shapes and sizes. And remember that term macrosomic was going to be for your large babies that are greater than 4,000 grams. As far as their genitourinary system goes, their kidneys are a little immature at birth. Their glomeruli are small, and the renal blood flow is about 1/3 of an adult's. They have a decreased ability to handle an increased water load. And so we want to be careful with too much fluid. That's why it's not recommended to give babies any other fluid other than breast milk. So we don't want to overload them. Their renal tubules are short and have a limited capacity for reabsorbing important substances. And they have a decreased ability to concentrate urine and cope with fluid imbalances. So it's just important to keep them as balanced as we can because they don't have the ability to do that themselves. We as nurses want to make sure that we record their first void so that we can identify if there's any problems. Usually babies will have at least one void every 24 hours or more for the first couple of days until the mother's milk really comes in. That usually happens around day 3 of life. And at that point, we should see wet diapers increase to be about 6 to 8 wet diapers per day once the mother's milk has come in. As far as normal male genitalia go, we should be able to detect testes in the scrotum. Usually they descend before birth. Occasionally they won't, and that is something that needs to be reported to the provider. If the testes don't descend into the scrotum and stay inside the body, that can create sterility in baby boys. And so it's really important that if they don't descend on their own, that they have surgery to bring them down so that they will be capable of manufacturing sperm and having children later in life. So babies are born uncircumcised, and then it's up to the parents whether or not they want their baby boys to be circumcised. We'll talk about that in just a second here. So this is normal male genitalia, and then you can see the picture of the uncircumcised fetus versus the circumcised penis. And then I also gave you a picture here of what we call hypospatus, where the urethra is positioned under the penis versus being at the tip of the penis. That is a problem that needs to be reported, and we definitely wouldn't want to do any circumcision on a baby that presents with hypospatus. So it's just a finding that we need to report. So circumcision is going to be removal of that foreskin on the penis. Some benefits include a decreased risk of penile cancer, fewer UTIs and fewer STIs. Some disadvantages could be infection and hemorrhage. So in our babies that the parents elect to have that baby circumcised, that's one of the nursing responsibilities we have, is to monitor post-procedure any increase in bleeding or any signs and symptoms of infection. We want to make sure the parents understand the signs and symptoms of infection when they go home. Normal female genitalia, it's not uncommon to see swollen labia on baby girls. They might also have a slight discharge from their vaginal area as leftover from the hormonal effects from the mother. And we always want to make sure that parents know to wipe their baby girls from the top to the bottom and never to bring the wipe up from the bottom back up to the top, because that can lead to urinary infections. So all of these pictures would be normal findings for female genitalia. For the integumentary system, some babies are born with what's called lanugo, which is just this very fine hair that can be found maybe on the shoulders or the upper back. It usually disappears within a week of birth. And usually the more premature a baby is, the more lanugo you're going to see. Other times babies are covered in what we call vernix, which is it's kind of just a really thick, cheesy-like substance. It will eventually kind of just be absorbed into the baby's skin and it'll go away. Babies that are born more premature have more vernix, so that's one of the ways we can identify a preterm baby from a term baby. There's less vernix on our term babies. And then we also want to make sure that their skin is normal in color. It shouldn't have any kind of yellowing to it. We would call that jaundice if there is a yellowing of the skin, especially if it develops within the first 24 hours. That's called physiological jaundice. And that's very important to report to the provider, as an increase in jaundice can cause brain damage in the first 24 hours especially. So this picture on the left is just showing you what a baby covered in vernix might look like, and then the baby on the right is showing you what lanugo looks like. So again, super important to report jaundice that develops within the first day of life. It can be very detrimental to the baby. As far as their GI systems go, they begin to function very shortly after birth. Meconium could have been passed already. If not, it usually is passed within the first 24 hours. Meconium is a very thick, black, tarry-like substance, and they can have several stools of meconium for the first couple days, and then eventually the stool color and consistency will change over time, depending on how they're fed and what they're fed. We can see some different variations here in their stool cycle. And you can see how as the meconium works through their body, the stool kind of changes into a more kind of yellowy, pasty color. So this is an example of meconium. This is an example of what stool would look like in a breastfed baby. It looks a lot kind of like mustardy color with it looks like seeds, and that is a normal finding. And then we have a baby with that's fed formula. It looks less seedy, more pasty. Still kind of that kind of yellowish green color. Babies are prone to having hiccups. Some of them can be constipated. So just important to let the parents know what's normal and to let their providers know if they have any problems down the road. It's really important that we make sure parents know to use good hand hygiene and to ask others, anybody who's going to handle their baby, to wash their hands, including healthcare providers. They have a lesser immune system response, and so it's really important that we prevent any infection that they might be susceptible to. We tell the parents, as far as the umbilical cord goes, to just leave it open to air and to monitor for any signs of infection there. If the umbilical cord clamp or stump gets infected, they might see drainage, redness to the area, and maybe some heat to the skin, so that would all need to be reported to their providers. As nurses, we hope that we would be able to start educating our patients even during the labor process about what's going to be normal and what they can expect when they go home. We definitely try not to overload them with education right before they're walking out the door, but rather spread it out over a period of time so that it's not so overwhelming and they might actually retain some of the education that they're receiving. And it's also important to back everything up with written words so that they can refer back to it if they have questions when they get home. Some areas that we definitely want to include discharge teaching on would be the basic infant care, so diapering, bathing, keeping the baby warm but not too warm, how the baby should sleep on their back, alone in their crib, no co-bedding. So safety measures like that, making sure they have a car seat and know how to use it, making sure they know how to assess the baby's temperature, and when to call their providers, different things to look for, immunization schedules, future appointments, and signs and symptoms of what to report to their providers. So that's the end of this chapter. As always, if you guys have any questions, please let me know. Otherwise, I will see you next week.